55 hours, 10 seconds.
Good morning, everyone. Welcome to another episode of the 260. With me here, I have my co-host, Taylor Finn.
Hello.
And our special guest, Dr. Scott.
Good morning.
Good morning. And Dr. Scott is our medical director for Fort Wayne Fire and TRAA. And do you do anything else besides those two?
Medical director for Lutheran Air.
Oh, yeah, that too.
And also medical director of the emergency department at Lutheran.
All right, so Dr. Scott, let's dive into you. So how did you get started? Were you a paramedic before?
I was.
So tell us about that.
Sure. Many years ago, when I was a little kid, I really wanted to be a doctor, which is very unusual. I grew up on a farm. Nobody ever even went to college where I grew up, and so I loved science, and I wanted to be a doctor because I loved science. Not so much I wanted to help people, I just like science. Yeah. And as in many things in our lives, we have what are called explosive events, right? And so in the 9th grade, in this little tiny high school, we're playing basketball. We're the basketball team practicing. And we were running wind sprints. For those of you who play basketball know what that is. It's a punishment for doing something wrong that the coach didn't like. Back and forth, running back and forth. And one of my teammates collapsed on the floor. And this was in like 1975. So we knew CPR then. I knew CPR. That had just sort of come out, and they were starting to teach that to the public. But, we're in a small town. there's a defibrillator maybe on the show Emergency, but there wasn't such a thing where I grew up. And so, he died. And so for me, suddenly the science of wanting to be a doctor, it turned into, I could probably help people. It became more of a, not just the science, but how can you apply the science to your classmate who's on the basketball floor? He most likely had primary VFib, right? That was his problem. And that could have been fixed as it is today many times with a defibrillator. And this is, why it's really, now that we have AEDs in schools and stuff, this is a great thing. But back, many years ago, that wasn't the case. So at that point, I'm like, this is really, I want to be a doctor, but I really want to help people. And there was something about being out in the field, being in the school, being outside of the hospital setting. And at that time, the show Emergency was on. It just had come out. Then, the Los Angeles County Paramedics. And there was a couple programs in Ohio. I think Columbus Fire had a program. Toledo, I think, was starting a program. So I was very interested in that. I wasn't going to give up on being a doctor, but I thought, I want to be a paramedic first because that's a quicker way to get to people. So when I graduated high school, I went to there were 2 paramedic schools in the country. One was in Kansas. The other was in Honolulu. I went to the one in Kansas, a 1,600-hour program immersed with the medical school. And I then returned to where I grew up, and we didn't have 911 then. So I was the only paramedic like in the entire county. And this in January of 1981 was my first save with a 48-pound defibrillator. So a guy collapses at a gas station. The defibrillator weighed 48 pounds. It was called a 450 SL. You're lugging that thing around, you almost have a cardiac arrest yourself. But defibrillated him into a successful rhythm. And from that point on, I'm like, this is good stuff, right?
Yeah.
We have science. We actually help people. So from my point of view, it pretty much took off from there in terms of being a medic. Did that primarily through college. Actually did that while I was in medical school too. Actually flew as a flight medic in med school. And then decided to go, still pursue my dream of being a physician. And then it was just an obvious thing for me to do emergency medicine. So that's why my residency was in emergency medicine. Just seemed like a natural path for me. Then I was in the Army. I was in Desert Storm. I was a flight surgeon in the Army. And that was an interesting job.
How did you transit? Like that's like quite a leap there. So you went paramedic and you were working, being a paramedic while you were in school to be a doctor. And then after you got out, you decided to join the Army?
Well, actually, I got a scholarship from the Army to go to medical school. Yeah, I had four brothers. I was born and raised on a farm. My parents didn't have any money. I didn't have any money. Interest rates for student loans were 16%. It just was crazy. And so for me to go to medical school, I pursued a military scholarship.
Okay.
And that's how I ended up being in the Army. And then there was obviously a payback for that in terms of time. And I did a lot of interesting things in the Army. Desert Storm was one of them. I was also trained in NBC warfare, in nuclear, biological, chemical warfare. And because part of my last duty station, which was in Honolulu, that was a tough place to have your last duty station.
Yeah, that sounds rough.
It was good. I was in charge of the medical aspects of the demilitarization of the chemical weapons in Europe. That was done in a place called Johnson Atoll, where they moved all the weapons out of Europe and moved them there to burn them off, about 750 nautical miles southwest of Hawaii. So I did that for 3 years with the Army as well, where you're walking around with a gas mask and Valium, 2-pan chloride in your pocket, atropine, in case there was a release of agent, that were all stored in these M55 rockets that troops put on. We moved and put them into this place so they could burn them off like at 2800 Kelvin to destroy those weapons. So, it was kind of an interesting job. Got to see firsthand what chemical weapons do. To train for that, you basically went to Aberdeen Proving Grounds, and you would PETA doesn't want to hear this, but you would put like a drop of VX nerve agent on a monkey, and you would see what happens, and it's pretty horrible. And then your job was to resuscitate the monkey with a combination of chemical interventions, atropine, things like that, intubation, all that stuff. So it's really bad stuff.
Yeah.
You really would rather not have that stuff out in the environment. And the people who thought that up, pretty crazy people.
Yeah. So you said Desert Storm. What was your role in that? Can you talk about that?
I was assigned to the 507th ambulance company, which was a flight unit. And, you just hang out in the desert for months, shaking spiders out of your boots. And then all of a sudden there's a war. And it only lasted, the actual battle itself only lasted about 100 hours.
Yeah.
And then there was just, going to casualty collection points, putting wounded in helicopters, and then doing the triage part of it in a combat surgical hospital.
Yeah.
So
that's
a lot of trauma in a short period of time.
Yeah.
Were you the only doc, or I'm assuming not?
No. The military has a very good battlefield medical system in terms of how there's gradations of, your combat medics, your field triage stations. Then you just kind of move up the line in terms of casualty support hospitals, and then you keep moving back, and you end up in Germany at Ramstein or something like that. So a lot of I still remember that growing up with the Vietnam War on TV. They said you had a greater chance of surviving a traumatic event in Vietnam than you did on the streets of the United States, right? Because the medical system was so well advanced in the military, and it continues to do that.
Yeah.
In terms of how you manage trauma in particular. And that's where the whole blood initiative really came out of, from the military in terms of how we would field resuscitate wounded troops. So you learn a lot when you're in a situation like that. So it was, it was a lot of fun. It's a lot of, it's a lot of trauma in a situation like that. So that was probably the most difficult aspect of Desert Storm, is really after the fact when, they had all the refugees and, all those places and all the medical care and then the withdrawal of medical care there as a policy. And so, But for me, I never was one much for battle, but I felt like I could contribute being there to help take care of the men and women soldiers that were, being injured. So I was,
Yeah. So I watched MASH growing up. I still watch MASH. Okay. Like it's my falling asleep movie. So I kind of envisioned that. How much of that, like in the tent?
pretty true.
Pretty true. Yeah.
Pretty true. We didn't have a still, where you could make
Yeah.
like martinis. We didn't have
Yeah.
one of those, but yeah, that's pretty
Darn.
much it.
You weren't that cool.
And at least when they brought them in on helicopters, they weren't on the skids; they were
Yeah.
inside.
Yeah.
But those were the original medevac helicopters. Putting them on the skids, and it was crazy. It was before my time, but
So
I
big-
enjoyed MASH. Yeah, the last episode I was in college at Ohio State. I did go to Ohio State, by the way, just for those of you who hate Ohio State.
OH.
And I had a night class, which was the same night as the last MASH episode, and they actually canceled classes.
Oh, wow.
Have you watched MASH, Taylor?
Yeah.
I've seen it. I've not watched the whole thing.
Oh, I've
So-
watched. I love MASH. I have all the seasons. It's nuts.
You've in a short period of time, it's been kind of wild. Like you're in the high school basketball team, like a peer of yours dies, like, and then
Yeah.
you become a paramedic, and next thing you know, you're in the Middle East. Like, wow, that's a lot going on
It was.
in a short period of time.
Yeah, it was. Yeah, and it was. Yeah, it was interesting. I glad I did it.
Yeah.
I'm glad to be out of the military. But
How long did you serve for?
11 years,
11 years. Wow. Good chunk of time.
good chunk of time. Yeah, I just was materialistic then in my life, and if I left the military, my income like more than quadrupled.
Yeah.
And then I actually had a choice of I really don't have a choice. I still wear the same thing every day when I go to work, but I didn't have to be I just one of those things. So
And I got to wear scrubs. Scrubs are nice. They're just.
yeah, except when it's 5 degrees out, it's cold walking to work.
Yeah,
in
they don't
scrubs.
make
no,
they don't make warm
no
scrubs.
flannel
really.
scrubs. No flannel
Yeah.
scrubs.
No flannel scrubs. We can invent that.
Yeah, for anyone with some patent ideas, there you go.
But for me, the fun thing about the military was that I was able to put that to use in the civilian sector. So when I left the military, I went to Florida. I ended up in Gainesville, Florida, where I ultimately was the medical director of SHANS at the University of Florida, which is the Level 1 Trauma Center. I also was a consultant contractor for FEMA. And so I spent also about 18 years doing deployments with DMAT and FEMA. And so, and especially with flight surgeon experience. So, I was in Katrina, wildfires, floods, storms, inaugurations, all kinds of sort of mass casualty events, and got a lot of experience traveling in that type of environment. And I really liked that because as that whole system matured, you could just show up to a DMAT, a tent hospital in the middle of a wildfire or, post-hurricane recovery. And, you train and you know what your role is. And as a physician, you could, we just move people in and out of positions because the doctors can't take a lot of time off of work, as an example. So you just spend a week or two in New Orleans or, wherever you're being deployed by FEMA or Homeland Security, depending who owned DMAT at the time. So got a lot of really interesting experience with that in terms of how to manage multiple people with no hospitals, no infrastructure in terms of natural disasters.
I had no idea you had, I guess, such significant experiences. It's pretty incredible.
The other really cool thing I did being at the University of Florida, we had the contract with NASA. I trained as a NASA flight surgeon, and then I did all the shuttle launches. Most of the time when the shuttles launched, I was there, and then when they landed, I was there. And it was a really cool gig. There's really not a lot you can do, honestly, if the shuttle blows up. I mean, really. But we did a lot of training, a lot of preparation for that.
Yeah.
But it was really neat to watch a launch at 2:00 in the morning with the shuttle taking off, and it's like the sun coming up and the earth's shaking and all the car alarms are going off. And so, it's pretty cool. And then taking care of the astronauts when they hit the runway. And and they've been in space for a while. They're all, they're vomiting.
What
they
kind
have
of things are
space
you
legs. You
expecting
can't
to
stand
see
them up.
from that? Like,
Do they need medical attention right
Yeah,
away
well,
normally?
early
or-
on in the shuttle, as an example, you had to learn how to take off an astronaut suit, right? You just don't, we got some pretty cool scissors now in EMS, but you got to be real careful what you're cutting in an astronaut's suit, because some of them, as an example, had central lines, and because they were doing experiments, right? They're drawing blood, doing all kinds of stuff in space, which you don't know anything about, because it's not public information. And so, if your guy has a subclavian line, right, you don't want to just be running your scissors across his,
that might cause a problem.
It'd be a serious
Yeah.
problem.
Yeah.
And there's a trick to getting the helmet off, and you just have to be taught stuff like that.
Wow.
I'm like bewildered right now. So what? I have to ask this. What made you come to Fort Wayne, Indiana?
Yeah, I ask myself that a lot here. Is it 2 degrees outside this morning or something like that?
Just a nice chill time in the Midwest as an ER director.
Right.
A nice, easy gig.
Yeah, that's what it was. Actually, it kind of came back full circle. My dad had died, and my mom was actually living by herself on the farm where I grew up, which is about 2.5 hours from here, to help her transition, and she died. Two of my brothers were still in Ohio to help take care of her, and then we have grandchildren in Decatur.
Yeah.
So that was really the reason why. Kind of, after 30 some years, kind of come full circle back to the Midwest. My wife's not from the Midwest, so I had informed consent about the weather and the conservative politics. She did not. So it's been kind of a
Long for the ride.
Been interesting.
Yeah, but at least Allegiant flies straight to Florida,
Yes.
Fort Wayne. So
Yeah.
sometimes we can take a quick break.
Yeah. Do you have any interesting, I guess, stories from like the space launch triaging? Like the ship got down and then we had this emergency and this is how we handled it. Like just an unusual scenario that people listening like probably don't know much about. I mean, I know I have zero schema for taking care of astronauts who just entered the atmosphere.
Yeah, that's failure is not an option, right? That's their mantra, and all that. They had some failures in some of the shuttle launches, unfortunately. Nothing. I mean, kind of some fun stuff like when they land. There's always this photo opportunity, right, on CNN where all the astronauts are standing in front of the shuttle. But some of them really can't hardly stand, or they're throwing up. So you got to pop them with some Zofran, and you try to figure out who's the 2 most stable guys or girls. You guys,
You guys be up
put them on
front.
the ends. You got to put them on the ends like bookends, and help them. Get that post landing picture in front of the shuttle.
Well, they earned it. Yeah.
You almost need those stands that you'll see like dolls on. Like you need a doll stand for the astronaut.
Well, sometimes there's like some guy back there holding them up, but. Yeah, so
Photoshop's come a long way.
The unsung heroes.
the other thing administratively that a very, very important concept that came out of the Challenger explosion was the concept of groupthink. And groupthink was when they really did a root cause analysis on that launching that shuttle. There were people in that room who said, I don't think it's a good idea to launch this shuttle because we've never tested these O-rings at this temperature. It was like 34 degrees, very cold at Cape Canaveral for the launch. But there was a lot of pressure because there was a school teacher and there's a lot of public pressure to take that launch. And so the overwhelming folks in the room decided it was a go. But there were some people in the room who really didn't think it was a good idea. And the whole concept that came out of that was what they called groupthink, which is you got to be really careful when you have a group of people making decisions and you don't allow somebody to honestly speak up and say, wait a minute, I think I got a problem here.
Yeah.
Something's wrong with this. And so, empowering people in the group, right, to do that. Kind of the aviation concept of cockpit aviation, right, where everybody's allowed to speak.
Mm-hmm.
Doesn't matter who you are. And yeah, as you know, if you've ever been on a helicopter crew, everybody's responsible for the safety of that helicopter. So, it's not just the pilot looking for wires. Everybody's looking for wires and then, in radio antennas. So the entire crew's responsibility, and you're responsible to speak up. And a lot of that came out of that NASA work from the Challenger, where there were some people who had clearly some reservations about what was going to happen.
Yeah.
So, and that was really a very valuable lesson for not just for NASA, but for a lot of us.
Yeah. I mean, you could say that there'd be parallels to that in what we do on 911 calls.
Oh,
Like, it's
absolutely.
not all
Absolutely.
on the lead person. Like, if you think or see something that is concerning, like, that's your responsibility to say something.
Absolutely.
Or we're all human, and sometimes people zig when they should zag, and you got to be able to depend on your crew to have your back like that.
Yeah, and it's hard because, both in the military model, the fire model, and even the team leader model of resuscitation is just that, right? There's a team leader who's leading the team, and this whole read back of verbal orders and things. Well, sometimes there's something that's not happening or something that's happening that somebody in the team recognizes, but there is this pressure not to speak up.
I don't want to cause a hubbub. I don't want to.
Because, and part of it's the way we train.
Yeah.
And the way that this stuff is taught. So, you really have to empower people to speak up when they see something that, they see something, say something. Right?
And it doesn't matter how many years of experience you have. Like, you could have just a minute of experience and you're like, oh, this doesn't feel right. And you could be saying that to someone that has 30 years, like, speak up.
Yeah, and that's the fun part about, especially after COVID, we've had a lot of, in the hospital example, and even in EMS, we've had a lot of locum tenens, right? Folks, nurses, doctors, and we even recently had paramedics, that came in from other systems to work with TRAA. And sometimes that's really good because they come in from the outside and they see things differently, and they question. They say, why do you do it this way? And you're like, I don't really know why we do it that way, because we've always done it that way. That's why we do it. When in fact, there may be another way. And it's not necessarily a better way. It's just another way.
Mm-hmm.
I like teaching there's more than one way to skin a cat. Like, it's because I do it this way.
Absolutely. Absolutely.
And, just what works for me, but that doesn't mean it's going to work for you.
What's your favorite method of skinning a cat?
Start from the rump and go to the top.
Good heavens.
Fair enough. A segue to something else I want to talk with you about, or we want to talk with you about. You mentioned with Vietnam and blood in the field. So you've been working with TRAA, you're their medical director, and they're starting to carry blood.
Right.
When are they going to start doing that?
Wednesday, there was a press conference down in the city with the mayor, and actually it was announced that on the 28th of January, we're going to be fielding blood. I don't know if it's exactly going to be the 28th of January, but we're very close.
Okay.
Yeah.
So I've spent taken me about a year to get this program up and running. There's a lot of rules.
Mhm.
Blood bank folks are they're very black and white, and we are 50 shades of gray in EMS. So there's a lot of hoops to jump through. There's cost, there's training,
Mm-hmm.
and then there's people that are supportive, and there's people who are not supportive in the medical community. So they say it takes about 18 months, and if we pull this off in the end of this month, it would have been about a year to get this program.
Good goal to have.
To get up and running. Yeah.
So I guess with our crews being out there, like, this is something that they could expect to see every now and then.
Right. So we're calling it Blood Without Borders, which means that it'll be carried by supervisors or chase medics with TRAA. But anybody can, primarily in the city, but anybody can request it. And we have some automatic dispatch protocols that if falls greater than 20 feet and penetrating trauma and some other things, that a blood medic who's identified, dispatch knows, 911 knows who those people are. They know who's carrying blood and where they are in the city. They'll dispatch them automatically as a blood medic.
Okay.
So, and because TRAA 911 also dispatches for county fire, obviously if the county fire departments are and the fire districts are, they can request it as well.
Yeah, that might affect mutual aid.
Yeah, exactly. So that's why we call it Blood Without Borders.
Yeah.
They can go anywhere with this blood.
That's incredible.
Yeah, the small amount of research I've done on blood, I did read something that if you can get blood before you go into cardiac arrest, your survival and better outcomes, patient better patient outcomes is significant. Is there any other data, I guess we can
Yeah,
kinda
there's
throw
two
it out there?
published studies. One was done in New Orleans, and the other was
Mhm.
done actually in Washington, D.C., where they showed a 30 to 35% reduction in death, primarily in penetrating trauma. Those two cities have kind of a propensity for that. And actually, it was how it's reported out is it's actually, this is a strange way of looking at this statistic, but it decreased the homicide numbers in those cities. Now, the same number of people are getting shot.
Yeah.
It's just not as many of them are dying.
Better outcomes.
Yeah.
And so, clearly, once you're in traumatic arrest, you're in trouble.
Yeah.
Yeah.
You're in trouble. And so, it's identifying those patients that have acute blood loss, either medical or trauma, and then starting blood sooner. Not only does it keep them alive, but down the road, the patients who get whole blood in the pre-hospital setting, they actually use less blood products in the hospital. So overall, I mean, it's a good thing overall.
Yeah.
So for us, the criteria will be, acute blood loss, traumatic, or GI bleed, postpartum hemorrhage,
Mhm.
a dialysis fistula that breaks open, or post tonsillectomy bleeds. I mean, you can think of some scenarios where the patient's exsanguinating,
Mhm.
not always trauma. And then the protocols will be for the administration of 1-2 units of whole. We're going to be carrying whole blood, as well as TXA.
Let's say, is that going to change the way that TXA is administered, or are they just completely compatible? Is there any
Blood.
considerations
From
that
a
need to be
priority
made?
point of view, blood's number one. TXA will be number two. And if we give 2 units of blood, then we also need to give an amp of calcium
Okay.
because of the chelating agents that are in blood, and it drops the calcium in the patient's body. So that's the protocol. Basically, it'll be 2 units of blood, 1 to 2 grams of TXA, and a gram of calcium chloride.
And that TXA is in a 100 ml bag, dripped in over 10 or so minutes.
Yeah, 10 minutes.
Okay, awesome. When a patient is receiving blood or has received it, they're in the process of like exsanguinating. Does that complicate their like clotting factors or anything like that? When I'm administering blood, when I still have a hole, is
Well,
it just
yeah.
going to start clotting right away now that they're getting circulating blood?
No, I mean, the whole blood has got plasma, platelets. It's got all the things in it to help with clotting. I mean, again, the primary approach to an exsanguinating patient is to stop the bleeding.
Yeah.
Right. So if you can get access to it, if an extremity, injury, tourniquets, right, as an example. The problem is the trunk, right? Gunshot wounds or ruptured spleens or a GI bleed where they got
Internal
soft tissue
trauma.
varices and they're just exsanguinating from that blood loss. So with whole blood, at least we're giving them plasma that has clotting factors and platelets as well. But the purpose is to keep them alive long enough so that the endoscopists or the surgeons can stop the bleeding. You mentioned about the hole and the bleeding in the hole, and that's the other reason why we used to just in the beginning, we just would like slam people with fluids, right? 1 to 2 liters of fluids right up front. And now, we have this concept of permissive hypotension, right? We want to keep patients so that they're adequately perfusing, but we don't want their blood pressures really high because it's going to make the bleeding worse.
Mhm.
So, and we know that saline probably is not the solution of choice for resuscitation of blood loss patients. So, really blood, I think, is the key.
I guess what's your take on our different solutions, and have you ever considered like trying to push for a different type of solution that we put?
It's
that
a
we
good question. I
could
mean,
carry?
the obvious one sort of is lactated ringers. Should you be using lactated ringers? The surgeons like lactated ringers. It doesn't seem to contribute as much to at least the theoretical acidosis that saline does.
Mhm.
But there's another solution called Plasmalite, which is a balanced pH solution. Actually, Baxter, which was the maker of most of the saline in this country, whose plant was destroyed in a hurricane in North Carolina, we had this big saline shortage, right? And so the FDA allowed them to import Plasmalite, and primarily made in Spain and New Zealand and the United Kingdom. And that's used in European countries a lot. This balanced electrolyte it's got a pH of 7.4. So there may be some room for that, and And sometimes, this is one of those things where unforeseen consequences of your normal saline plant being destroyed. Well, maybe there is a better solution after all. Could be plasma line,
Innovation.
right? I mean,
Yeah.
and just because we had to have something. So that's an example of, and in some places use some different types of solutions.
You talked about groupthink, and saline is one of the things that I think quite a few people have kind of cocked their head at. Like, seems to be a lot of data suggesting that there might be some other options out there. Well, why are we doing it? Well, we've always done it. Like, well, that's not
pretty
a good
much.
reason.
And, for the most part, kidneys are a lot smarter than doctors, right? And so the kidneys, they just figure all that stuff out and they just get rid of all that excess sodium and everything.
Kidneys are smarter than doctors.
right. So,
That's
it's
fun.
when your kidneys are failing that, and that's why some of the smartest doctors out there are nephrologists, right? Because when the kidneys decide not to work, everything just goes to, goes into array. So, saline's probably okay because most people, their kidneys figure it out. But in a resuscitation scenario, there may be some better fluids or no fluids, right? I mean, that's probably the most important thing, particularly in trauma, maybe no fluids, blood only. Interesting, there's been some discussion in trauma about trauma arrest. And so in some programs, once you're in trauma arrest, they don't give blood because the chances of survival are very low. But there is what we call the pseudo PEA trauma arrest, right? Where you got a PEA, you have an EKG rhythm, right? PEA. What you don't have is an ultrasound probe to see that there actually is cardiac contractility, right? Their heart is actually working. You just can't feel a pulse. There's not enough fluid there. And so should you, particularly with trunk trauma, should you not do CPR at all? And should you give blood, right? So if you have the pseudo PEA, and probably the same is true even in a medical arrest. In PEA arrest, there are people who are in PEA that truly have electrical mechanical dissociation, which is the old name for that, right? EMD. And that's true, or you look at the heart with ultrasound and there's no motion at all. But in some medical arrests, in PEA arrests, there is actually cardiac contractility, right? I mean, it's there. So instead of doing CPR, when we have ultrasound abilities, we run vasopressors and we do other things. Because there's another problem. The heart's working. What's the problem? Either the pipes or, you got to get vasoconstriction or you got to get fluids or blood or depending on what the clinical scenario is. So, which, also speaks to, I think at some point, ultrasound's probably going to be in the field. I mean, once it gets a little bit cheaper, I think.
It's very encouraging to hear.
Handheld ultrasound, I think, will help make some clinical decisions on the use of blood, use of fluids, more aggressive vasopressors as an example in these, what we call pseudo PEA arrests, both medical and trauma.
That would be, I think that would revamp
it
much.
It would probably change the way we manage that patient.
Many
population.
calls, yeah.
I am a pro for having ultrasound in the field. I absolutely love it.
Right, and the probes are getting smaller and they're getting smarter, and now we have AI that even identifies on the screen, right? These are curly B lines, and we see that in congestive heart failure. So,
wow,
this is the sliding sign of a pneumothorax. I mean, and now with AI, I mean, it just actually recognizes it and tells you right on your screen what's going on. Yeah. So it's not going to be long that the cost, I think, we'll be able to do it.
Yeah,
I
know. And you probably know this. Like, I know there's a lot of agencies in Florida that they have it, like the supervisors have ultrasound, and I know that they are teaching it in a lot of their paramedic programs now, which is pretty cool.
Yeah, I think it's going to be our next tool, honestly.
Yeah,
I think so. And as an ER doc, it does help me make some decisions, clinical decisions in terms of like PA as an example, and obviously it helps me in terms of vascular access.
Yeah.
Both, peripheral and central lines.
That would be huge.
Yeah.
Yeah.
Could we backtrack a little bit to the saline situation? I'm just thinking of people listening, and you say what you said again. You mentioned in some resuscitative scenarios, like no fluid at all. And I'm trying to think about it from the perspective of crews listening in because we don't have blood here. So we're talking about it because
Right.
I think it's valuable for our crews to have that in the back of their mind. You're going to be seeing this. This is why. This is how it works.
Right.
This is the ins and the outs. But so I don't want them to think like, oh, well, I'm not supposed to give saline. Like Dr. Scott said, no fluids. Like, but that's in our protocols. So like,
Sure.
So do you mind maybe explaining that a little bit more?
Yeah,
Like,
absolutely. Yeah, primarily in the trauma patient, saline. I mean, they've looked at saline versus no saline as an example. Patients who get saline do worse. I mean, you got to stop the bleeding first of all, and secondly, saline is what you talk about coagulation factors as an example, clotting factors. When you administer saline, you're either further diluting those in the body.
You're not magically getting more clotting factor. You're just
no
thinning
clotting
it out.
factors in saline that I'm aware of. So
no. Drats.
yeah, in a medical patient and a dehydrated patient, okay, I think there's room for isotonic fluids, whether it's saline or ringers or plasmolite or whatever we're giving. So I would never want the message to be that no fluids, but I think you have to really think about fluids in a bleeding patient about whether it's the right thing to do or not.
What about our burn patients?
And burn patients, and again, probably more lactated ringers than saline in those particular patients. Most burn centers want us to use ringers instead of saline. They just don't want the sodium chloride load. Burn patients, certainly fluids. I mean, there are many patients, that are dehydrated, vomiting, diarrhea. How do we fix that? We fix it with fluids.
Mm-hmm.
So would never say not to give fluids. But you have to just look at the scenario and what are you trying to accomplish? If you're trying to fill up the tank again, do they need blood or do they need fluids? Because what have they lost?
Yeah. In a scenario where, okay, so say I use my critical thinking skills and it seems like blood would be the most appropriate decision to give this patient, but it is not available right now for the chase medic, the supervisor. They are in another scene doing the same thing, and I'm a fire crew, and all I have are fluids. Is that better than nothing?
And again, I would go back to the concept of...
I know, what are you trying to do?
What are you trying to do? And also the concept of permissive hypotension, right? So we allow patients to have lower blood pressures that are bleeding until we can stop the bleeding. And so, you don't want that patient's blood pressure, 120 over 40, right? You don't need that. Maybe you need some fluids to get him to systolic of 70 or 80, because at least then you're perfusing organs, but you don't need them normal tensive.
So maybe just the old adage, look at your patient. Are they perfusing? Are there signs of, that they're not perfusing? Are there signs of...
Right.
Yeah. So, okay.
Yeah, absolutely. And the other sort of a little bit of a different concept is you should always resuscitate before you intubate, right? Just to remember about when you put positive pressure in somebody's chest, that's either has blood loss or fluid loss.
Mm-hmm.
You change the whole dynamics of blood return to the heart. And, every patient that you put on CPAP or intubate, right, they always get hypotensive. Or they have cardiac arrest with, 2 minutes later, and you say, I knew that guy was going to code. I'm glad I intubated him. Well, maybe the fact that you intubated him caused him to code, right? Because he wasn't resuscitated properly.
Well, yeah, it's CPAP and a bunch of nitro on board.
So sometimes patients need a little bit of push dose epi before, not after, right? As a concept, right? You want to resuscitate patients before you put positive pressure in their chest.
Is that something that crews could get orders for prophylactically? Like, hey, this is my goal. These are my plan. I want to avoid a certain outcome. How do you feel about some push dose pressors?
Yeah, I'm fine with it. Right, you just got to think through the scenario and what's going on with the patient. What do you think's wrong with the patient?
Yeah.
But you should always really think very hard before you put positive pressure in somebody's chest, because you're going to change all the hemodynamics of that patient's cardiovascular system. So, sometimes they don't need to be intubated. They need fluids, vasopressors, or blood.
Are you seeing crews talk to you or your staff on med control? Like, how often is that happening?
It's pretty unusual. Yeah. You got a pretty good set of protocols. So, in my point of view is that, make some good decisions out there, right? I mean, that's what we're asking you to do, is try to, do the best you can to figure out what's going on and make some good decisions. I understand you have very limited data. You haven't got an ultrasound. You haven't got, the things that I have at my disposal. But you use your assessment skills and try to, and what's your end goal? What are you trying to do? What do you think's wrong, and where are you going?
I really like that you just said what you said. There is a lot of fear with our crews, and part of what we're doing, like, we are humans, but also, like, you can never tell the future. And so if you're making a decision in good faith with all the information you have, and it didn't work out the way that you had hoped or would have been ideal, it doesn't necessarily mean that you did a bad job. It doesn't mean that
not.
you are going to lose your job. Like you just said, I have, with everything I've been given, all the information I have, this is my plan, and this is why I wanted to do that. And I think crews need to feel equipped to have that thought process, instead of like, I don't want this to happen. And so they end up maybe not doing anything at all.
No, I absolutely agree with that. And, we see a lot of what I call protocol violations, right? Where somebody did something not by protocol. And some of the reasons, you just have to be able to explain why you did it. And if it sounds legitimate to me, fine. If not, then the protocols are there for a reason. They're best practices. This is what we think is the best way to manage this problem with the science that we have right now.
Yeah.
And, obviously there's a medical legal aspect of the protocols itself about how pre-hospital providers are actually practicing. So, we're not encouraging rogue medics, right?
Yeah. Don't go rogue, people.
But, sometimes,
you talked about those 50 Shades of Gray.
Yeah, no, absolutely. Absolutely.
Yeah.
Sometimes, you got to make a clinical decision that you would take another path. And you can always consult medical control.
Yeah, that goes
right?
back.
That's the other thing. Is
call
you
your bed
and
control.
Say, right, and say, hey, what do you think? And, most of the calls I've gotten are pretty good, asking me about, I've got some push dose epi calls. What do you think about push dose to epi? Yeah, that sounds good. Or how about another dose of whatever we're giving? So, I think you always have the opportunity to have that discussion.
Yeah.
Understanding that, you're in a time crunch and you're in an environment that, I have the leisure of being able to, have a room, keep out visitors, and, think about things. You don't. So you're in a very fluid environment. So that all has to be taken into account, right?
You mean you don't have dogs barking in your
No,
ER?
we do have a dog in our ER.
Oh,
but,
yeah, I know.
we do.
Oh,
Vader.
gosh,
But yeah, but pretty quiet most of the time.
oh, yeah, she's so sweet.
Gets a little mouthy sometimes. But in general, pretty quiet.
Is it still Vader?
No. Vader retired. Vader retired.
When you say retired, do you mean retired?
No, I think Vader's still around. No,
Okay, good.
But all dogs go to heaven. So,
I was just going to call it today. I was like, that's it. I'm done, guys.
It's all good.
Can't handle it.
Yeah, and a 6-year-old patient the other day came in for an asthma exacerbation, and I asked her, what brings you in to see us today? My opening line, patients, and she said, I came to see the dog. So, then.
What was your next reason for coming here?
What
All
was
right,
the
let's
other
get the
reason?
dog in here and listen to your lungs.
Has a little lab, has a little doctor coat on, and stethoscope around.
But so I went and got the dog.
Yeah.
I want to wrap this up with just one more question. What drives you to be passionate about EMS and emergency services?
Yeah, that's a great question. So really my passion is being a medic or being a doctor. You help one patient at a time. Mm-hmm. And you make a difference in people's lives, one at a time. When you're a medical director and when you have responsibility for an entire system, you help a lot of people, right? And so it's the ability to affect the care for thousands of patients that I'm not taking care of personally, but I have oversight for how those patients are taken care of. Mm-hmm. So for me in EMS, every patient that you touch is an extension of my medical practice. And I truly feel that way, that, I want you to treat those patients the same way that I would treat them. And I want those patients to have a good experience and a good outcome. And I can do that as a medical director and affect thousands and thousands of patients' lives much more than I can as a practicing physician.
Yeah. Well, we appreciate you. I absolutely love you as a medical director. You're very active. Like you knew that we were starting a podcast. You're like, hey, I want to know what you guys are doing. Like I might come
Yeah.
on here and there. So we absolutely appreciate it. And we're gonna end this one here, guys. And just remember, leave it better than you found it.